Okay, so welcome back to this next video in which we are discussing rheumatoid arthritis and anti-rheumatoid drugs. Okay, so we're currently in the process of discussing the pathogenesis of rheumatoid arthritis, and we've discussed that the pathogenesis of rheumatoid arthritis begins with this infiltration into the subintima of the synovial membrane of adaptive immune system cells. So we've seen that two forms of CD4 positive T cells come into the subintima, and those are T helper 1 cells and T helper 17 cells. We've also seen that you get B cells coming into the subintima and plasma cells coming into the subintima, and these plasma cells are going to be producing antibodies which are specific for some autoantigen that is yet unidentified in the synovial joints. Okay, but we'll discuss that autoantigen more later on, because more is known about it than what I've told you so far. Okay, right. We've then discussed that this infiltration of adaptive immune system cells results in the production of three important molecules here, okay, which are going to drive the chronic inflammatory response that is characteristic of rheumatoid arthritis. Okay, so we've discussed that the T helper 1 cells secrete the cytokine interferon gamma, IFN gamma. The T helper 17 cells secrete the cytokine interleukin 17, and because the plasma cells are producing these autoantibodies, which are specific to an autoantigen present within the synovial joint, then we're going to get immune complexes being formed in the extracellular fluid of the synovial membrane, and therefore also in the synovial fluid, because the extracellular fluid of the synovial membrane and the synovial fluid are in continuum. So basically these three molecules, they go up in the extracellular fluid of the synovial membrane and in the synovial fluid. Okay, and they're going to drive this chronic inflammatory response. Okay, and the reason that they do it is mainly interferon gamma and the immune complexes activate these synovial macrophages, these type A synoviocytes of the synovial membrane intima. Okay, and once those synovial macrophages are activated, they're going to start releasing a huge number of pro-inflammatory molecules that are going to maintain the inflammatory response. So as long as the adaptive immune system cells are here producing these molecules, then you're always going to have the synovial macrophages being activated to release the pro-inflammatory molecules which are going to maintain the chronic inflammation, and that's how you get the chronic inflammatory response in the joints in rheumatoid arthritis. Okay, so we've discussed then that what's going to happen is these type A synoviocytes, these synovial macrophages, are going to release all of these pro-inflammatory molecules, and we've listed them off here. So we've got examples of cytokines, so tumor necrosis factor alpha, interleukin 1, interleukin 6, and macrophage colony stimulating factor. We've then got an important chemokine here, interleukin 8, and we've also got two important prostaglandins, prostaglandin I2, also called prostacyclin, and prostaglandin E2. Okay, right. Now of those, the really important ones in driving the inflammatory response are tumor necrosis factor alpha and interleukin 1. These are so important that they're given the grandiose title, the primary cytokines. Okay, and these have effects on the microvasculature in the subintima of the synovial membrane to cause the inflammatory response. Okay, so they cause the vasodilatation of the arterioles, okay, which increases blood flow to the synovial membrane subintima. They also cause the endothelial cells of the capillaries and the postcapillary venules to contract, okay, which opens up much bigger gaps between endothelial cells so that fluid can leave the bloodstream and go into the extracellular fluid of the synovial membrane, and therefore into the synovial fluid. Okay, and this isn't just any old fluid, this is fluid filled with proteins from the blood, okay, notably coagulation cascade proteins and complement proteins that are usually put into the blood by the liver, okay, and they're very important in fighting infection at sites of inflammation, basically. Okay, so that endothelial cell contraction and the vasodilatation then are going to lead to fluid accumulation in the synovial cavity, and therefore we're going to get swelling of the synovial joints, basically. Okay, In addition, the endothelial cells are going to start recruiting white blood cells, leukocytes, from the blood, okay, a process known as leukocyte extravasation. Okay, and here we get to talk about a few more cytokines. Interleukin 8 released by the type A synoviocytes, and interleukin 17 released by the T helper 17 cells. Those are really powerful chemotactic agents for neutrophils. When you have high interleukin 8 and interleukin 17 in an area, you get loads of neutrophils piling into that area. So you're going to get neutrophils coming into the extracellular fluid of the synovial membrane, and also therefore into the synovial fluid of the synovial cavity. Okay, so you end up with lots of neutrophils in the synovial cavity of this swollen joint, basically. And we'll see how those neutrophils contribute to the destruction of the hyaline cartilage later on. Okay, right. So now what I want to do is continue this story on. I want to discuss firstly interleukin 6 and what interleukin 6 does. Then I want to discuss the chronic changes that are going to occur to the synovial membrane, okay, because of the chronically elevated levels of tumor necrosis factor alpha and interleukin 1. And I want to stress again that as long as those adaptive immune system cells are infiltrating the subintima of the synovial membrane, then this is going to continue, basically. The production of these pro-inflammatory molecules by those synovial macrophages is going to continue. Okay, and that's how the adaptive immune response, the autoimmune reaction, is going to drive this entire process. Okay, so we're going to discuss now first the interleukin 6 and then the chronic changes that are going to occur to the synovial membrane. Okay, so let's start with interleukin 6 then. Okay, so interleukin 6 is one of these pro-inflammatory cytokines released by these synovial macrophages, okay, and it's actually going to end up going into the blood, okay, so the synovial macrophages will release it, it will then go into the extracellular fluid, and it will end up going into the blood, and it's going to have effects on peripheral tissues, basically, principally the liver, okay, so it's going to go to the liver and it's going to affect the activity of the hepatocytes in the liver, okay, and this change in activity that it causes within the liver is something known as the acute phase response. Okay, called so because it's characteristic of acute inflammation. So when you've got an acute inflammatory response occurring in a portion of tissue, then usually you get the acute phase response occurring in the liver, basically, because of interleukin 6 released from the site of inflammation, which then goes and acts on the liver. Okay, of course, in rheumatoid arthritis, you're going to be getting interleukin 6 chronically being released into the blood, so you're going to be getting a chronic acute phase response, basically. So what is the acute phase response? Well, basically, the acute phase response involves the liver producing more of those proteins that are involved in inflammation. Okay, so what are the key proteins here? Well, the complement cascade proteins, okay, also the coagulation cascade proteins. So proteins that are essential for the inflammatory response, proteins that are essential for either attacking pathogens directly, such as complement proteins, or for trying to curtail the spread of the pathogen, such as the coagulation cascade proteins. So remember, the coagulation cascade proteins result in the production of a fibrin meshwork. Think of a spider's web that is designed to trap the pathogen where it is and stop it from spreading, basically. Okay, so because we're using lots of those proteins at the site of inflammation, we want the liver to start making more, and that's what the acute phase response is all about. Okay, so the liver is going to start producing more complement and more coagulation, and that's what the acute phase response is, and it's interleukin 6 that tells the liver to do that. Okay, interleukin 6 also has effects on the brain, okay, and it also leads to some of the conscious experiences of being ill, basically. So it's what is responsible for making you feel tired when you are ill. So interleukin 6 causes fatigue. It also causes that reduction in cognition, basically, a reduction in the ability to think. So, you know, when you are ill, your ability to do maths problems and plan for the future and problem solve and things like that, cognitive functions, is reduced, basically. Your ability to think is reduced, and interleukin-6 is one of the things that is responsible for that. Okay, right, so interleukin-6, remember, it's going to be chronically released into the blood. It's going to be causing chronic acute phase response. It's also going to be causing fatigue and reduction in cognitive ability, or chronically, basically, when it's elevated for long periods of time. Okay, right, now, let's now talk about the changes that are going to occur in the synovial membrane in a joint that is suffering from rheumatoid arthritis. Okay, so we're going to talk about the fact that both the intimal layer of the synovial membrane and the subintimal layer of the synovial membrane are going to expand, basically. Okay, and this is going to be under the influence of tumor necrosis factor alpha and interleukin-1. Okay, so basically when you have chronically elevated tumor necrosis factor alpha and interleukin-1 in the extracellular fluid of the synovial membrane, this triggers changes in the synovial membrane, and I want to now discuss these changes with you. Okay, so let me draw my basic picture of a synovial joint out again so that we have something to point at, have something to compare it to. Okay, so here, these are the two bones. Okay, then we know that the two bones are covered on their ends by the hyaline cartilage here. Okay, or the articular cartilage. And of course, I'm drawing an exaggerated picture here. In reality, the articular cartilage would be articulating, basically. They would be against one another, okay, rather than having this massive great gap here. Okay, but for simplicity, I'll draw that gap there. Okay, and then you'll have the joint capsule here, which remember is made up of that fibrous membrane, and then the synovial membrane, which is the inner portion. Okay, and remember the synovial membrane consists of those two layers, the intima and the subintima. So I'll just colour in the synovial membrane here in orange. Now, you remember me telling you that the intimal layer of the synovial membrane consists of usually around 3 layers of cells. Okay, 3 layers of those type A and type B synoviocytes. So if I now draw in a zoomed picture of the synovial membrane, remember it consisted of these 2 layers here. This layer here is the intima. Okay, and this consisted of usually around 3 layers of cells, like so. Well, basically, under the chronic presence of tumor necrosis factor alpha and interleukin-1 that you're going to get in rheumatoid arthritis, basically this intimal layer is going to expand hugely. It's going to go from being around 3 cell layers thick to being around 10 cell layers thick. Okay, so it's going to go like this. So there's 6 now, 7, 8, 9, 10. Okay, so it's going to become much, much thicker. You're going to basically get hyperplasia of the synoviocytes, okay? They're going to start over-dividing so that you produce a much thicker synovial membrane. Okay, now it's not just the intima that's going to get thicker, the subintima is also going to get thicker under the influence of tumor necrosis factor alpha and interleukin-1. Okay, so you're going to start getting more connective tissue produced in the subintima. Remember, the subintima is this stroma, and that consists of a lot of connective tissue with the odd fibroblast scattered amongst it, and then it's got lots of those blood vessels. Basically, that layer is also going to get much bigger under the influence of tumor necrosis factor alpha and interleukin-1. And what even starts to happen is the synovial membrane starts to invade, basically, over the hyaline cartilage. Okay, so if I show this, what's going to happen is the subintima is going to get so big that it's going to start pushing the synovial membrane out, like so. Okay, so you're going to start getting this extension. This is all going to become synovial membrane, basically. And what you can just imagine is the synovial membrane being gradually pushed out and out and out, and it just keeps growing over the hyaline cartilage. Okay, so this is because of this expansion of this subintima, more and more connective tissue being produced. Of course, you're also going to have to be producing more and more blood vessels, so you're going to be getting angiogenesis occurring to produce new blood vessels, and it's just going to expand, push pushing out against the hyaline cartilage, so that now the border of the synovial membrane is out here, basically, like so, and you've got now synoviocytes pressed against this hyaline cartilage, and this is not good, because as we're going to discuss in a moment, the type B synoviocytes, the synovial fibroblasts, are going to start secreting loads of molecules that are going to break down the hyaline cartilage. Okay, and of course it's not just this that's going to extend, it's this one as well that's going to extend. Okay, so you're going to get extensions there, you're going to get extensions there, and basically the synovial membrane is going to start to fill the joint cavity, basically, the synovial cavity here. Okay, and it's just going to extend like this in this very unhealthy way. And this extension, this invasion of this connective tissue is what's known as Panis, basically. Okay, so when you get invasion of this sort of connective tissue, this huge expansion of a connective tissue that invades into this area where it's not supposed to be, that's known as Panis. So Panis doesn't just apply to rheumatoid arthritis. It's a more general concept than that. It's the concept of an expansion of this connective tissue, this stroma of the subintima, okay, that starts to invade into places where it should not be. Okay, but the key example of Panis really is in rheumatoid arthritis, where the synovial membrane gets bigger and bigger and bigger and invades into this area on top of the hyaline cartilage of the joint. Okay, right, and this is one of the things that leads to the stiffness of joints, okay, the filling in of the synovial cavity with this fibrous connective tissue, basically. Okay, right, so what I now want to discuss is the destruction of the hyaline cartilage that covers the bone surfaces. Okay, so basically the type B synoviocytes and also the chondrocytes in the hyaline cartilage are going to start releasing molecules that are going to break down the hyaline cartilage, basically. Okay, so this is again guided by the chronically elevated levels of tumor necrosis factor alpha and interleukin 1. So these are doing everything, basically. These control the chronic inflammatory state. They control this Panis, basically, this growth of the synovial membrane and this invasion of the synovial membrane over the articular cartilage and gradually filling in the entire synovial cavity. And now what they're going to do is they're going to start causing the type B synoviocytes, okay? So remember the fibroblast, the synovial fibroblasts, which are colour in green here, that are in the synovial intima here. And they're going to start causing those to start releasing molecules, specifically proteases, which are going to be breaking down the extracellular matrix of the hyaline cartilage. And not only do they activate the synovial fibroblasts to do that, but they also activate the chondrocytes in the actual hyaline cartilage itself. Okay, so interleukin 1 and tumor necrosis factor alpha are going to activate the synovial fibroblasts, okay, which are these cells in green in the synovial intima, okay, also called the type B synoviocytes, and they're also going to be activating the chondrocytes, which are in the articular cartilage themselves. Okay, so they're the cells which are dotted around in the extracellular matrix of type 2 collagen, remember? Okay, and these two types of cells are now going to start releasing proteases, basically, and the proteases are going to break down the extracellular matrix of the hyaline cartilage. They're going to break down that type 2 collagen, basically. Okay, so that's how you get destruction of the hyaline cartilage. Now, it's not just the production of the proteases that contributes to the destruction of the hyaline cartilage, okay? It's also the inactivation of the endogenous inhibitors of proteases in the hyaline cartilage. So let me just explain this. So basically, most tissues are protected by from proteases. Okay, most tissues have dotted around the place proteins which are designed to inhibit protease enzymes. So if I just draw my protease enzyme here, okay, basically most tissues make proteins and put them around the tissue in the extracellular fluid, okay, that can inhibit the protease. Okay, so this is a protease inhibitor here. Okay, so if you're going to destroy the hyaline cartilage, one thing that you need to do is produce proteases, and that's being done by the type B synoviocytes in this Panis tissue that's invading over the hyaline cartilage. It's also being done by the chondrocytes, which actually are in the hyaline cartilage, and that's happening under the influence of tumor necrosis factor alpha and interleukin 1. But you also need to inactivate these protease inhibitors in the hyaline cartilage. Otherwise, they're just going to inhibit the proteases, and you're not going to actually get the breakdown of the type 2 collagen. So what is it that inhibits these protease inhibitors that are in the hyaline cartilage? Well, basically, this is where the neutrophils come in. So remember I told you that as part of the chronic inflammatory response that you're getting in rheumatoid arthritis, you get loads of neutrophils in the synovial fluid. So I'll draw one here. Here is this neutrophil. Okay, now basically what the neutrophils do is they start releasing horrendous molecules, okay, reactive oxygen species, free radicals, okay, and the principal example of a free radical, I mean there's loads that they can produce, but the principal example of a free radical that you should know about is the molecule superoxide, okay, which is O2 negative dot. Okay, so let me just explain this molecule for you in case you're not familiar with it. So normal oxygen molecules consist of two oxygen atoms double bound together. So let's just draw an electron cross diagram, dot cross diagram for this. Okay, so here are these two bonds between these two oxygen atoms. Okay, and we'll show the electrons of this oxygen atom as crosses. Okay, so here are this oxygen atom's free lone pairs of electrons. Again, in these two bonds, it will have put one electron into each. And then let's show the electrons of this oxygen atom as dots. Okay, and again, it will put two electrons, one into each of these covalent bonds here. So that's the dot cross diagram of the outer shell electrons for these oxygen atoms. Okay, now to turn this dioxygen molecule, as it's called, into a superoxide molecule, what you basically have to do is fire in another electron. So here comes this bad electron. Okay, you have to fire in this bad electron at the oxygen molecule. Okay, now what happens when you fire another electron at this oxygen molecule? Well, of course, it's going to give the oxygen molecule a negative charge, and that's where the negative here comes from. But basically what happens is it breaks one of these covalent bonds here, okay, and one of the electrons, you can imagine, goes back to each of the oxygen atoms. So you can imagine this electron going back to this oxygen atom here, and this one going back to this oxygen atom here. Okay, and then this electron is going to pair up with one of these electrons on one of the oxygens. So let's say it's going to pair up with this oxygen's electron that it's taken back. So basically, if I draw what you're going to end up with, here are the two oxygen atoms again. I'll just move this over here. Okay, you're now only going to have a single bond between them. Okay, so that's this bond still remaining. Now this oxygen here is going to have three lone pairs of electrons. One of them is made up by that bad electron that's come in here, okay, and the electron that this oxygen atom took back from the second of the two two covalent bonds, okay. And then this oxygen over here is going to be the problem, because it's now going to have two lone pairs of electrons, and then it's going to have an unpaired electron like so. So this oxygen has a negative charge, this one has a free radical basically. Okay, so free radicals are just where you've got an unpaired electron basically. Okay, and that makes the molecule extremely reactive. So this is the superoxide molecule, which we would write as O2 negative dot basically, and it's an example of a free radical molecule. Okay, so neutrophils start producing superoxide basically, along with loads of other really horrendous molecules, other free radicals and other really reactive molecules. Okay, you might ask, well, why on earth do they start producing those? Well, basically, think what the body is doing here. The body thinks that there is some horrendous pathogen in the joints. Okay, the adaptive immune response is attacking your joints. Okay, the body assumes that the adaptive immune response is doing a good thing, that there is some horrendous pathogen in there that it's trying to attack. Okay, you are now sending in the innate immune system to help. You've got this chronic inflammatory response going. Your bringing in these neutrophils. What are the neutrophils supposed to do? They're supposed to kill pathogens. Okay, so the idea is that neutrophils can go into an area and start spitting out these horrible, horrible molecules, basically, like superoxide. And basically the idea is just poison the pathogens out, basically. Okay, the superoxide is incredibly reactive. It just reacts with DNA, proteins, anything, basically. Lipids, the key constituents of life, basically. Okay, and it's designed just to kill, basically. So that's why the neutrophils are releasing these molecules. They're trying to poison out pathogens, basically. They're trying to kill pathogens. The problem is, of course, there is no pathogens, okay, and instead you're going to poison your joint. So basically, the neutrophils start producing these incredibly reactive molecules, the principal example of which is superoxide, okay? And the superoxide ends up going and reacting with protease inhibitors and inactivating them, basically, destroying their functional ability. Okay, so that's how you inactivate protease inhibitors, through these horrible molecules that neutrophils are releasing. Okay, so to summarize then, the chronically elevated tumour necrosis factor alpha and interleukin-1 in the extracellular fluid of the synovial membrane and in the synovial fluid itself in this inflamed joint are going to cause the chondrocytes of the hyaline cartilage and the type B synoviocytes, these synovial fibroblasts of the synovial membrane intima, to start releasing proteases, which are going to break down the type 2 collagen of the hyaline cartilage that covers these bone surfaces. Okay. In addition, to make things worse, the neutrophils are releasing these horrible molecules which are going to inactivate protease inhibitors. So the result basically is that you're going to start breaking down the type 2 collagen molecules of this articular cartilage. So this cartilage that I am colouring now in red is going to start getting degraded, basically. You're going to get the breakdown of the hyaline cartilage that covers the surface of the bone. So this is the first part of joint destruction that we have looked at, basically. So as you get this extension of the synovial membrane over the hyaline cartilage, this Panis, you're also going to be getting the degradation of the hyaline cartilage underneath. So that's going to start going, basically. Okay, now it gets worse. Not only are you going to degrade the hyaline cartilage, okay, but you're actually also going to start breaking down bone, the bones underneath here. Now, how does bone degradation occur? Well, we know what causes degradation of bone: osteoclasts. Okay, so how does this chronic inflammatory response in this synovial joint cause the recruitment of osteoclasts? Well, this is now where we go to one of those final cytokines that we haven't yet mentioned, okay, which is released by the type A synoviocytes, the synovial macrophages. Okay, so we're going now to MCSF, macrophage colony stimulating factor. Okay, so let's have a look at what this does. So basically, macrophage colony stimulating factor is going to go into the blood like interleukin 6, and it's going to act far, far away from the synovial joint, basically. It's going to go to the bone marrow, basically. Okay, and it's going to cause the production of osteoclast progenitors, or precursor cells to osteoclasts. Okay, so what produces precursors to osteoclasts? Well, basically it's the hematopoietic stem cells in the bone marrow. Okay, so the hematopoietic stem cells produce all of the hematopoietic cells, okay, but they're also responsible for producing osteoclast precursors. Okay, so if I draw one of these cells, these are deep within the bone marrow, basically. Okay, and when macrophage colony stimulating factor activates these hematopoietic stem cells, the hematopoietic stem cells are going to start dividing, and some of their progeny are then going to go on and differentiate into osteoclast precursors, and these osteoclast precursors are then going to go into the blood. Okay, so we'll draw this here. Okay, so we'll colour in the hematopoietic stem cell here in red. Okay, and then we'll have the osteoclast precursor here in green. So you're going to start getting the production of osteoclast precursors. Osteoclast precursors are going to go up within the blood. Okay, now what's going to happen? These osteoclast precursors are going to make their way through the blood to our inflamed synovial joint. Okay, and of course this won't just be happening in one joint in the body, this will be happening in many joints, and we'll discuss which joints it's actually going to occur in later on. Okay, so the osteoclast precursors are now circulating in the blood. They've been produced by the hematopoietic stem cells because of macrophage colony stimulating factor. Okay, now what's going to happen, they're going to come into our inflamed synovial joint, okay, and then they're going to start building osteoclasts. Okay, now to build an osteoclast out of osteoclast precursors, you need the osteoclast precursors to receive a certain type of stimulation. Okay, so let me firstly just show the construction of the osteoclast from the osteoclast precursors. So if we now have our bone here, okay, which has now lost the hyaline cartilage, the hyaline cartilage is going, okay, and we're now going to have an osteoclast assembling on the bone. And remember, osteoclasts are these huge, great multinucleated cells. They're made by fusing together loads of these little osteoclast precursors. And I'm sorry about how small this picture is. Okay, so these are the osteoclast precursors, this little cell here. Okay, and basically to form an osteoclast, which is the big giant of a cell here, what you need to do is fuse together lots of osteoclast precursors to make that osteoclast. Now, in order for this to occur, the osteoclast precursors need a certain type of stimulation to drive them into fusing together and producing an osteoclast, basically. And they have a special receptor that needs to be stimulated, basically. And this special receptor is known as the receptor activator of nuclear factor kappa B, or for short, it's called the RANK. Okay, so RANK stands for the receptor, that's the R, activator, that's the A, and then the NK is for of nuclear factor kappa B, NF kappa B, which will abbreviate to NF kappa B like so. So this stands for, if you want the full name of this, nuclear factor, that's the NF, and then this little K-like symbol there is the Greek letter kappa. Okay, and this is nuclear factor kappa B, a very important transcription factor in immunology. Okay, right. So basically, these osteoclast precursors, if I draw an osteoclast precursor now bigger here, okay, these have this receptor on their surface, so I'll draw this here. Okay, this is one of these RANK receptors, the receptor activator of nuclear factor kappa B that we'll have here. Okay, and in order to become an osteoclast, in order to get the osteoclast precursors to actually produce you an osteoclast, you need to have the receptor activator of nuclear factor kappa B on the surface of these osteoclast precursors being stimulated. Now, what stimulates the receptor activator of nuclear factor kappa B? Well, it's what's known as the receptor activator of nuclear factor kappa B ligand, okay, which is written RANK-L. Okay, so this stands for the receptor activator of nuclear factor kappa B, which I'll just abbreviate to RANK, and then ligand. Okay, now there are two different forms of the RANK ligand. There is a soluble form, which just means a secreted little protein that can go off and activate the receptor activator of nuclear factor kappa B. And then there is a membrane-bound form, which cells put on their surface. Okay, and basically, you are now going to have the expression of the RANK ligand driven on certain cells, specifically on the type B synoviocytes, by a bunch of these cytokines that are elevated in our rheumatoid arthritis joint. Okay, so basically, the type B synoviocytes, which remember are those synovial fibroblasts, okay, one of the key cells of the synovial intima, okay, these are now going to start expressing RANK ligand, and they're going to be producing both the soluble form of RANK ligand and also the membrane-bound form of RANK ligand, which they'll put on their surfaces. Okay, and now what induces this expression of the RANK ligand? Well, it is certain cytokines, and you've guessed the two ones that are involved in everything. So tumor necrosis factor alpha and interleukin-1 drive the expression of RANK ligand on the surface of the type B synoviocytes, and also interleukin-17 is very important, released by the T helper 17 cells, remember. Okay, so the chronically high levels of tumor necrosis factor alpha, interleukin 1 and interleukin 17 then are going to drive the expression of rank ligand by these type B synoviocytes. If I just go back to this picture here, these are the type B synoviocytes, remember. They are within the synovial intima. Okay, they are going to start putting on their surface rank ligand molecules, and they're also going to be starting to throw out soluble forms of the rank ligand. Okay, this is now going to be going over to our osteoclast precursors here, binding to the rank receptor here, and I'll show the soluble form because that's easier to show. Okay, here is the soluble form, but the membrane-bound form will also be working. Okay, the osteoclast precursors can come into contact with the type B synoviocytes and therefore can bind to the membrane-bound form of rank ligand. Okay, so here is the rank ligand binding to the rank. Okay, and this is then going to trigger these osteoclast precursors to start fusing into a large osteoclast, which you're going to be getting forming on the surface of the bone, basically. Okay, and now we know what osteoclasts do once you formed them. Okay, they are going to start secreting proteases, which break down the type 1 collagen molecules of the bone matrix, and also acid molecules, which will break down the bone mineral, okay, the hydroxyl apatite, okay, and therefore you're going to be starting to get bone erosion. Okay, so this is how bone erosion occurs in rheumatoid arthritis, basically. The macrophage colony stimulating factor triggers the production of osteoclast precursors from the bone marrow. Okay, these are going to be coming into our inflamed joint. Okay, and then the expression of rank ligand, which is driven by the chronically elevated levels of tumor necrosis factor alpha, interleukin 1 and interleukin 17, is going to then drive these osteoclast precursors to fuse into osteoclasts on the surface of our bone, which is now exposed because we've been degrading the hyaline cartilage which covers the surface of the bone, and now you're going to be getting the erosion of the bone, basically. Okay, so what's going to start happening is you're going to start getting huge cracks in your bone like so, and then what can actually end up happening is the Panis, this sort of invasive connective tissue of the synovial subintimate, can actually extend into these cracks. So if I show the rheumatoid arthritis joint now, here we have the bones with these sort of cracks in like so. So there's one bone. Okay, and then I'll show the other bone here, sort of another sort of cracking like that. Okay, now let's have the fibrous membrane of the joint capsule still out here. So this isn't really involved in the pathology. Okay, so this is just the fibrous membrane. And now I'll show the synovial membrane, okay, which will have extended basically into all of these cracks. It will be just taking over basically. So all of this can now be just synovial membrane extending into the synovial cavity and gradually filling in the synovial cavity basically. Okay, there's invasive connective tissue known as Panis. Okay, right, so that's going to be occurring in the rheumatoid arthritis joint basically, and this is what leads to the gradual stiffening up of the joints in rheumatoid arthritis, this replacement effectively of the synovial cavity just with this Panis connective tissue. Okay, right, so finally to talk about two of those final pro-inflammatory mediators now, because if you remember I told you all of these inflammatory mediators that are released by the type A synoviocytes, the synovial macrophages. We've been through a lot of them now. We've done tumor necrosis factor alpha, interleukin 1 to death. We've done interleukin 6, we've seen interleukin 8, we've seen macrophage colony stimulating factor. We haven't yet seen these two prostaglandins here, prostaglandin I2 and prostaglandin E2. Okay, so I just now want to talk about what those two do. Okay, so prostaglandin I2, when I was talking about the inflammatory response that was induced by tumor necrosis factor alpha and interleukin 1, I said that those two molecules, tumor necrosis factor alpha and interleukin 1, they work on endothelial cells, okay, and they induce the production of prostaglandin I2 in the endothelial cells, and it's the prostaglandin I2 which causes the relaxation of the vascular smooth muscle cells around arterioles, and therefore leads to the vasodilatation. Okay, and that's one of the key parts of the inflammatory response. So in fact, the prostaglandin I2 that the synovial macrophages are producing directly is also going to contribute to the continued inflammatory response, basically. So this is going to contribute to inflammation. Okay. Meanwhile, prostaglandin E2 that's also produced, this is going to contribute to pain, basically. This is capable of activating receptors on the surface of pain neurons. Okay, neurons which convey information about pain. And basically, there is quite a bit of evidence now that what prostaglandin E2 does is it sets up rhythmic firing in pain neurons. Okay, so similar to the heart, where you have a rhythmic firing of action potentials which drives the heartbeat, the idea is that prostaglandin E2 being high can drive pain neurons to fire action potentials at this rhythmic sort of rate, which is what produces chronic pain, basically. Okay, so prostaglandin E2 is supposed to be extremely involved in the production of pain in these rheumatoid arthritis joints, and we'll see how that means that the NSAIDs, the non-steroidal anti-inflammatory drugs which block the production of prostaglandins, are quite effective painkillers for rheumatoid arthritis. Okay, but we'll come back to that when we discuss the anti-rheumatoid drugs. Okay, so for now that's what prostaglandin I2 and prostaglandin E2 do. Okay, right. So to summarise what is happening in rheumatoid arthritis, you're getting this autoimmune response which drives a chronic inflammatory response. And note, it's normally the other way round. Normally the inflammatory response occurs first, and then you get the adaptive immune response attacking. That's the way the immune system usually works. Here we've got the adaptive immune system going first, attacking some autoantigen in the joint, okay, and then that causes the chronic inflammatory response. Okay, so you've got a chronic inflammatory response, which means that the joints are going to be chronically swollen. Okay, you're going to have very painful joints. You're also getting the gradual destruction of the joints and the infiltration of this Panis tissue into the synovial cavity, which is gradually going to be making the joints stiffer and stiffer and stiffer, as no longer they're going to be able to move, because you're just getting this connective tissue filling in that gap between the two bones. Okay, so that's what's overall happening in rheumatoid arthritis. Okay, now, just before we end this video, what I want to do is tell you about which joints rheumatoid arthritis generally occurs in. Okay, so basically it starts in smaller joints and then generally extends to bigger joints. Okay, so common joints for it to occur in are the metacarpophalangeal joints. Okay, so metacarpophalangeal joints, and I'll show you these on myself in a moment. Okay, so this means the joints between the metacarpals and the phalanges. Okay, so basically those are these joints here. So the metacarpals are the bones in this portion of the hand here, and then the first phalanges are here. Okay, so these joints here are the metacarpophalangeal joints. Okay, also common joints for rheumatoid arthritis to occur in is the proximal interphalangeal joints. Okay, and basically that is the junction between this portion here. So these are the proximal phalanxes, these bones are the fingers. Okay, and then the second middle phalanxes here. Okay, so these joints here, this one, this one, this one, and this one, those are the proximal interphalangeal joints, okay, and they are also common joints for rheumatoid arthritis to affect, okay, and it will also affect the equivalent joints in the feet generally, okay. Then, as it gets more severe, it can affect bigger joints. So, for instance, it can affect the wrists, the equivalent one in the feet, which is the ankles, so you can also get it affecting the wrists and the ankles, and then as it gets worse, it can start affecting the elbows and also the knees, okay? But rarely does it go into other joints beyond that, okay? So elbows, and knees. So those are the joints which generally rheumatoid arthritis is going to affect. Right, so we'll call it there for this video. In the next video, what we're now going to discuss is we're going to go back and have a look at what drives that initial infiltration of adaptive immune system cells. Okay, so as I say, this bit that we've just discussed of the pathogenesis, starting with the adaptive immune system infiltration, that's the bit that's well understood. The bit about the autoimmune response is not so well understood and remains very controversial. Okay, so after looking at a basic review of how the adaptive immune response is initiated, we'll then look at theories as to what occurs in rheumatoid arthritis and what is this autoantigen that we are fighting, basically.